Tonight, we're going to be discussing Parkinson's disease and dementia and its treatment. And we're going to be talking here about the Parkinson's syndrome as we see it. We will also be discussing how it compares with Alzheimer's disease. We will discuss also its treatment with EXELON, which has been approved by the FDA, and the new EXELON patch briefly. The overview of the talk tonight on Parkinson's disease dementia we'll talk briefly about what Parkinson's disease dementia is. We're going to talk a little bit about the dementia of Alzheimer's type. And we're going to talk about the pathology and the neurotransmitters of both of these diseases. And then we're going to talk about the clinical features of Parkinson's disease dementia and the clinical trial that allowed the FDA to release EXELON in the treatment of this dementia with Parkinson's. Now, the manifestations of Parkinson's disease is important to recognize. And it is a syndrome. Everybody has their own disease. But it has three important clinical features: resting tremor, rigidity, meaning stiffness, akinesia, bradykinesia, meaning slowness, and postural instability. The first three occur usually early on. Postural instability occurs later. If it occurs very early, postural instability and falling, then it's probably an atypical Parkinson syndrome. The first three have usually clinical evidence of asymmetry. Now, there are other additional features to Parkinson's disease. One of the ones we're going to talk about tonight is the cognitive impairment, or dementia. But there can be mood changes, behavioral dysfunction, loss of sensation, or what we call olfactory disturbance, sleep disturbances like excessive sleep that occurs during the day, constipation, seborrhea dermatitis, pain, numbness, sweating, and other autonomic dysfunctions like orthostatic hypotension. The non-motor signs and symptoms of idiopathic Parkinson's disease are now being recognized more clearly. And it's very important to realize that these non-motor symptoms involve numbness, aching, pain, thermal changes like hot and cold, slowness in the mind or bradophrenia, slow thinking, dullness or dull thinking, sweating, anxiety, panic attacks, and mood changes. These are all non-motor signs and symptoms in Parkinson's disease that can be treated. Now, the considerations for therapy really are always very important in Parkinson patients. And I use this important aspect called the triad. The triad is here the evaluation of all drugs. It's efficacy, tolerability, and safety. Efficacy is determined by the clinical trials. Also, tolerability and safety are important. Now, there are several reasons to use drugs in idiopathic Parkinson's disease. One is theoretical, not proven. The FDA doesn't allow release of that. That's not why you use these drugs. Theoretical improvement for using drugs is a consideration. Then there's evidence-based. There is clinical trials that document that these patients have evidence-based improvement in various aspects that are endpoints in the clinical trial. Now, the etiology of Parkinson's, there is no known factor that is definite. There's no biological marker. But we think it's genetic and environmental factors that play a role. Rarely, there are families that have this significantly as autosomal dominant or autosomal recessive, but usually they're younger. Epidemiological studies suggest younger people are more likely to have genetic factors, and environmental factors probably tip over some of these patients, but environmental factors are more common as the patient gets older. We just haven't been able to nail down all those environmental factors. The epidemiology of Parkinson's is fairly well known. Number one, there's a lot of people. About 1 to 1.5 million people have Parkinson's. About 60,000 additional cases diagnosed each year. And this is a disease that is significant. Patients that have Parkinson's disease, across the board, about 40% of them will have some cognitive impairment. And if they've had the disease longer than 8 years, if you study these people very carefully with cognitive tests, about 70 to 80% of them will have some cognitive impairment or dementia. A patient who has Parkinson's disease is 4 to 6 times more likely to have dementia than an age-matched control. Now, Alzheimer's disease is a group of diseases. It's a neurodegenerative disease. It's a protein deposition disease, probably like Parkinson's disease. It involves beta amyloid, where Parkinson's is alpha-synuclein. But Alzheimer's disease has cognitive impairment associated oftentimes with some difficulty with speech or abnormalities of motor function or thinking or visual changes that occur. So Alzheimer's disease has what we call the beta amyloid senile plaque. And this shows that senile plaque on the left-hand side. Then on the right-hand side is the neuronal aspects, which are considered neurofibrillary tangles. And those are tau. The senile plaque is beta amyloid, and the tau is another protein. Now, the clinical symptoms of Parkinson's versus Alzheimer's have to be recognized by not just doctors, but significantly by the patients and the caregivers. And we know that in Parkinson patients, as compared to Alzheimer's patients, you're more likely to have major depression, fluctuations of attention and somnolence, more falls, more visual hallucinations, and, of course, more Parkinsonism. This graph shows in the blue the higher bar graph, showing that the higher the percentage is seen with the vertical line, and the various symptoms are on the horizontal line, and we see very clearly that Parkinson's have more of these symptoms than people with Alzheimer's disease. And this slide shows the neuropsychiatric symptoms that are characteristic of both. But what's important to know is that Parkinson patients are more likely to have probably hallucinations, they're more likely to have depression, and Alzheimer's patients are more likely to have problems like agitation and apathy and disinhibition and some repetitive motor abnormalities. Now, Parkinson's disease dementia can easily be diagnosed. It usually occurs after the first 2 years of the Parkinson clinical syndrome. If it occurs with dementia early on right away, we often think it's a Lewy body disease. But that doesn't make a difference treatment-wise because we use the acetylcholinesterase inhibitor EXELON in both of those cases. So people with Parkinson's have cognitive decline, they have frequent neuropsychiatric aspects, and they have functional disability. You have to exclude other dementias, and we have to realize that these problems with dementia really cause significant problems. They're a problem for the caregiver. There's significant aspects of caregiver costs, caregiver time, and caregiver depression that can occur. Now, I want to briefly mention atypical Parkinsonism and atypical Parkinson syndromes, because some of those have dementia. Multisystem atrophy, progressive supranuclear palsy, cortical basal ganglia degeneration, diffuse Lewy body disease, and frontal temporal dementia. Those can be seen as atypical, and each one of them will have some percentage of dementia if you have 100 patients with that clinical entity. What I often think about is the consideration that happens when a Parkinson patient gets dementia. The impact and burden of Parkinson's disease is significant. Cognitive and behavioral symptoms are significant. They cause caregiver distress, they reduce activities of daily living, quality of life. They're more likely to be associated with hospitalization, especially the hallucinations, and more likely to require nursing home placement. The risk of mortality is significant in people with dementia and Parkinson's. Now, the basal ganglia not only is involved in motor function, but it is involved in executing, integrating, modulating, and coordinating motor activity. But it also has to do with affect, emotions, reward. Probably sensory functions also occur. Now, the Lewy body is seen in Parkinson's disease. We talked about the senile plaque and the neurofibrillary tangle in Alzheimer's patients. But the Lewy body is in Parkinson's, and it's alpha-synuclein. And it occurs in dopamine neurons. And in Parkinson's, it's the substantia nigra, deeper in the brain, that is associated with the loss of neurons or dysfunction, and it reduces dopamine in the striatum. And you have less dopamine as a neurotransmitter. Now, Brock and Brock, pathologists, documented in a series of cases the pathological evolution in Parkinson's disease. And we see here on the left stage 1 and 2, then in the middle 3 and 4, and 5 and 6. And the reddish area documents where there is involvement pathologically. In the earlier stages, what we see is involvement in the olfactory nucleus and in the vagus nerve. And we know that Parkinsons oftentimes lose their smell. Then later on it goes into the brainstem in the substantia nigra, and in the latter stages it's involved in the frontal area and through other regions. Now, in these regions, in the forebrain and in other areas that have acetylcholine, there is a deficiency of acetylcholine both in Parkinson's and in Alzheimer's. But they're distinct disorders that have common cholinergic deficit. Acetylcholine is reduced. In Parkinson patients, the Lewy body pathology is in the cholinergic basal forebrain and in the brainstem. In the Alzheimer's patients, it's more in the forebrain, but also in some areas of the brainstem, but you get cholinergic dysfunction. Now, this cartoon shows us normal cholinergic function. In the presynaptic neuron, there is acetyl-CoA plus choline, and it's metabolically transformed into acetylcholine by the choline acetyltransferase enzyme. That allows acetylcholine, the neurotransmitter, to be packaged and then released. It's released in the synaptic cleft, and then normally it attaches to the cholinergic receptor at the postsynaptic receptor site. We increase the amount of acetylcholine in the synaptic cleft by inhibiting a substance, acetylcholinesterase, with the drugs like rivastigmine or EXELON, because it attaches to that and more acetylcholine is available. So the acetylcholinesterase can't break down the acetylcholine. That allows more available acetylcholine. Now, memory loss and behavior changes are very important in Parkinson's. 30 to 40% of all Parkinsons will have significant behavior and memory problems. But at 10 years, it's 80%. It gives you significant comorbidity. We use acetylcholinesterase inhibitors to treat that, and that's EXELON. And sometimes, off-label, not approved by the FDA, I will add in memantine. And as a last resort, we use neuroleptics. And if you use these acetylcholinesterase inhibitors, you can reduce the use of neuroleptics. Early diagnosis, early screening is key. Now, the cognitive profile in Parkinson's disease dementia has three important areas. One, impaired memory, meaning difficulty with retrieval of memory, less likely difficulty with recent memory. And this impaired memory usually has the phenomenon that it's benefited by external cues, and there's some preservation of recognition. Executive dysfunction is the second part of the cognitive profile of Parkinson's disease dementia. Concepts, problem solving, set shifting, going from one thing to another, is slowed. And tasks that require planning or sequencing are slower in patients with executive dysfunction. There's also attention impairment, reaction times, vigilance, and fluctuation of attention or fluctuation of alertness is significant. So the impaired executive function that is characteristic and oftentimes seen early in Parkinson patients involves poor judgment, poor difficulty with insight, memory retrieval deficit, poor planning, and you can document this by the clock drawing test, poor ability for mental search, such as verbal fluency, doing numbers of animals' names in 10 to 15 seconds or in 1 minute, and difficulty with concrete thought, such as proverbs, and reduced mental flexibility. Now, the Montreal Cognitive Assessment Test can be found on the web, and you can actually give that to patients, or you can give it to your spouse or someone, and it gives a good idea, and it'll explain it how you can use that test. That'll sometimes help significantly with testing for memory. So in neuropsychiatric aspects in Parkinson's, they're very common, and hallucinations are really one of the most important. The FDA allowed EXELON, or rivastigmine, to be released for the treatment of dementia in Parkinson's disease because it improves cognition and it improves some aspects of behavior abnormalities in Parkinson patients. This is a slide that just shows how this trial was set up. 650 patients were screened. It was given on a 2-to-1 basis, EXELON and placebo, and they all were given certain outcome measurements. The primary outcome measurement was a test called the ADS-COG, which is 70 questions measuring how the patient's doing with memory, and what we call ADCS test, which is a clinical global improvement with the input of the patient monitored by the doctor. And those were the two endpoints. Other secondary efficacy measures were activities of daily living and other neuropsychiatric inventories, the NPI. This slide shows the clinical trial. The vertical line here is mean change from baseline. Up is good, down is bad. The horizontal line is the baseline and the time frame, and the yellow is EXELON. And we can see that EXELON does much better than placebo up to 24 weeks. And this trial has actually been extended out in an open label up to several years. So what we found out with EXELON in a double-blind control trial is that it helps memory, improves not only the activities of daily living, but it also improves definite score measurements, the ADS-COG, and also the clinical global improvement. This was statistically significant. So EXELON did better than placebo. It was statistically significant, but that was also seen in activities of daily living and also in the neuropsychiatric inventory test, which is important because behavior is a significant problem. Now let's talk about, as we should, any drug that's given in a disease and the treatment of that disease, this important concept of adverse side effects. Remember this clinical triangle: efficacy, tolerability, and safety. That is what clinical trials give. Efficacy is determined by the hard scoring factors that you use in a clinical trial. But you also need to check for adverse side effects. And what are they? Well, EXELON, as compared to placebo, was much more likely to give nausea, vomiting, and it did make tremors somewhat worse. It gave diarrhea, some anorexia, but other things were not such a major problem. Interestingly, confusion was better. But nausea, vomiting, diarrhea were more in patients on EXELON than they were on placebo. But the patch is going to help that out some. But this is the capsule. It's also important to point out that some of these patients will have weight loss with anorexia. Now, this clinical trial showed that adverse side effects were not that great and safety was pretty good. Sometimes you have to worry a little bit about slow heart rate or bradycardia, but otherwise things were fairly the same in the patients who were on EXELON and placebo. Tremor did get worse when you used it in the treatment of dementia in these Parkinson patients. So, in summarizing the safety issues, this is a safe drug, EXELON, acetylcholinesterase inhibitor, the capsule. It's a safe drug in these patients with Parkinson's disease. Tremor can get a little worse. Sometimes you can adjust the Parkinson medicines to reduce that. Now, we do now have that's just released, and it's coming on the market. The FDA has released the EXELON patch. The advantage of the patch will be you'll have a patch once a day. You'll be able to put it on and take it off every day, and you won't have to worry about medications. And the adverse side effect profile is less than it is with the capsule, and more people will be able to get up to the therapeutic dose. This patch has a colored backing layer that you can see on this slide. It has an acrylic matrix, and then the silicone matrix is the adhesive, and there is a release liner that's present. The acrylic matrix is where the drug is, and these patches will come out in 4.6 milligrams per 24 hours and 9.5 milligrams per 24 hours. You'll give the lower dose for a month and then increase the dose. Now this slide shows us here that there is a significant improvement in the ideal study when you compare the patches against placebo. We have the comparison in the yellow with the capsule. We have the placebo, which is black, and we have the patch at 9.5 milligrams, and the blue patch at 17.4 will not be released. We see up is good. The improvement from baseline, the ADS-Cog, is better if you're up, and so down is bad. Placebo is not as good as is the patch or the capsule, but the patch may be a little bit better than the capsule, but it may not be statistically significant. The bottom line is that there's fewer side effects. And this, again, just shows in bar graph form change from baseline in the ADS-Cog. The capsule is in the yellow on the left. Up is good. The patch is 9.5 milligrams, and the highest patch, 17.4 milligrams, got better effect, but it had more side effects. And of course, placebo is in black, and it didn't do as well, and these patients had more side effects with the higher dose of patch, and most importantly, this patch at 9.5 milligrams did better than the placebo. Adverse side effects were less with the patch as compared to the capsule, but they were more than placebo. But by and large, there was less nausea, even though it was present some, and vomiting was less, and diarrhea was less. So what have we learned from tonight's talk? We've learned that dementia is common in Parkinson's disease. The longer you have it, the more likely you're going to get dementia. Earlier Parkinson patients are less likely to have dementia problems, but then behavior and dementia problems can occur. Parkinson's disease dementia is associated with cholinergic deficit. That's why the rationale is you can use an acetylcholinesterase inhibitor to increase acetylcholine, and you get improvement clinically. Parkinson patients have prominent executive dysfunction, and we've talked about what that means. And there's also significant neuropsychiatric symptoms associated with Parkinson's disease dementia. We know that EXELON improves cognition. It also improves activities of daily living, and it can improve behavior. So this is a drug that is the foundation for not only improving behavior, but also for improving cognition. A large portion of Parkinson patients will have some degree of dementia or behavior, and we want to analyze and screen for that. We know that this has an important impact on burden, not only on the patient, but on the caregiver. We treat because we want to improve activities of daily living, improve cognition, reduce behavior problems. We want to delay nursing home placement, reduce caregiver burden, reduce caregiver time, and hopefully reduce caregiver costs. This drug, EXELON, will improve cognition. So what we know here, very importantly, is that we can have significant benefit in our Parkinson patients. So essentially, in overview, we've discussed Parkinson's disease dementia. Not uncommon, more common as the disease progresses. We've talked about dementia of the Alzheimer's type. Both of these dementias are probably protein deposition diseases. For Alzheimer's, it's beta amyloid. For Parkinson's, it's alpha-synuclein. We talked about the clinical features, and we talked about the clinical trial. We know that we want to do things that are important to help the patient and the caregiver. I want to thank you very much for joining us tonight. I am Dr. D. Silver. Stay healthy, be well, and good night. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell, Jr., founder of Taco Bell, and by Elaine and David Darwin.